am Dr. Ira Kirschenbaum. I am the editor of the Journal of Orthopaedics Experience and Innovation, otherwise known as Joey, of which many people have taken credit for naming it that. I want to, there's going to be a lot of people I'll be thanking tonight, both participants as well as our guest author, Dr. Paul Sethi. I just want to make a couple of housekeeping comments. We're very pleased that Dr. Sethi wrote this editorial on a procedure that I probably don't know how to pronounce, Remplissage. And I'm sure the French will throw me out of France for the way I pronounced it. But it's exciting, and it's a lead into the Shoulder 360 course. So for those of you who are under a rock and have not known about this course, I strongly suggest you just look up Shoulder 360 and register. And I think it's going to be a very exciting course. So first, Paul, I'd like to introduce yourself.
Hi, Ira. Thank you so much for having me. I'm Paul Sethi. I'm an orthopedic surgeon in Greenwich, Connecticut, and I am part of the Shoulder 360 course this year in Miami, April 11th. So we're hoping to see all of you there.
13 to the 15, Paul.
Thank you, Ralph. That's what I meant to say.
Paul wants you to come on the 11th.
You're never getting those
Brains
glasses,
behind the
bro.
operation.
You're never getting those glasses, bro. I'll tell you that much.
Oh my God, this is going to be a tough audience tonight, Paul.
I'm ready. I'm ready.
So tonight, I expanded the topic a little bit to not only talk about the Remplissage, but just in general, anterior shoulder instability and shoulder instability, and where this procedure and other procedures land in your options of how to treat these patients. So explain it a little bit of your view of shoulder instability, how often you see it, and then we'll launch into the procedure that we're talking about.
So I guess I'll open it up with, look, I see a fair amount of youth athlete shoulder instability, whether it's a collision sport or, some sliding into base, shoulder pops out of socket, and then they come in to see me. And the question is, what is the ideal course of action for an individual whose shoulder is dislocated? And of course, there's so many things that are going to go into making that decision. But when you get down to it, if we take out this subset, and this is where I'm going with this, the subset of athletes who are going to continue to play sports at high school or at the collegiate level, their risk of recurrent instability without surgery is very high. Whether we want to call it 70, 80, or 90% after a single dislocation, it's high. And the challenge is how to best treat these athletes, when to offer them surgery, if to offer them surgery, and how to do it. I think what's really changed, in my opinion, and this is where I'll open it up a little bit, is that the risk of recurrent instability is not 3 to 5%, as some of us may want to believe or quote or cite. I think if we're talking about a youth who's a male, who's playing lacrosse in Baltimore or football in Philly or another sport, hockey in New Haven, the risk is much higher than 3 or 4%, and maybe closer to 15%. And what's even scarier is that each subsequent dislocation makes that risk even higher. So Brian Waterman quoted, 1 is enough and 2 is too many. So we've got all these different strategies on how to address instability, but it's not as good, at least I think, as reported. And I guess I'd throw it at Anand or Joe or Rafi. What do you really think the honest recurrent instability rate is in a collision athlete after arthroscopic surgery?
I'll take that one. I think it's arthroscopic procedures, especially you get to these kids rarely after their first dislocation. I mean, I think we do it more now. So you're getting to them second, third after the season's over. And I think their recurrence rate, especially if they continue playing, even in the best hands, probably like 20%. If you're doing simple Bankart, single row, simple suture repair.
Sharif Basai, you agree with that?
I think that's a fair number. I think it actually could be a little bit higher. I think that it's very clear that one dislocation, as you just said, is a lot and should be treated essentially immediately, but we have other factors that play into it, mid-season injuries and whatnot. However, once you get to that second one, I think that your risk goes way up. I know Pat's done quite a bit of work that he's published recently that shows that essentially even subcritical or even critical bone loss can still be treated with Remplissage. And I'm excited to hear from Pat, and that's one of the reasons I'm on, because I just haven't seen it, and maybe I just don't have that skill set. And so I just don't believe Remplissage is the panacea we think it is.
I guess that's a lead into Patrick. You want to just, how does it work, Patrick? Before we even get into like who and how does it work?
I think the whole fill the defect thing is a bit of a misnomer. I mean, we did a biomechanical study a couple of years ago with Ty Lee's lab, and really, if you look at that data, what you really saw is that it pulls the head posterior. So I think the biggest thing it simply does is provide a restraint to anterior translation. Yeah, it fills a defect, but I think that's the biggest thing that it does biomechanically.
So I guess, we've got this procedure, and before we even get into who indicated on, our people in the group, and everyone pipe in, whether it's Jacob Triplett or Bill Merle, or I think Don Buford just logged in. Are you encouraging first-time dislocators to have surgery even if they're in season? Has that changed? All of you people jump in.
Well, I'll tell you about it at Anna because that's my talk.
Well, I can't wait that long.
We need the slides.
Yeah,
I'll
Paul,
tell you
How
that.
many people on this call have had shoulder instability?
Okay, Joe, go ahead. Cool guy.
Well, no, I dislocated at 16, dislocated 20 times, and I had a Bankart. And I'm not a collision athlete by any means. And most of my patients aren't collision athletes. They usually collide with the refrigerator as they go to go eat. But
except when you're coming down the the thing and live, then you're a collision.
yeah.
A potential collision.
So I will say that in that elite group, that I think belt and suspenders probably makes sense. It's interesting how we've had a resurgence in 2008, 2009. Pascal was talking about this, and there was a lot of skepticism that what he was saying was a little bit of smoke and mirrors. It does restrain rotation more than he says, and that it's not necessarily as good a procedure as he was espousing. Now it's gained popularity again, and I just wonder why the pendulum swung that way again. I'm curious about that.
I think, Joe, I'll tell you why I think it's swung. It became easier. I used to get in. I mean, I'll admit, like a lot of people, you get to the end, you don't necessarily want to do something, or you think, well, I don't want to add that part. But because it became easier technically, I started doing it on ones that I was sort of on the fence probably. And then I saw, my dislocation rate reduced. I was like, well, maybe I should start doing that more and more.
Don Buford, you had a comment on the chat. You want to share that if you can?
Sure. I'm firmly of the belief that we need to try and fix these with the first dislocation, because I think everyone on this call has seen somebody come back after a second one, and it's changed from a straightforward, simple Bankart to now you're doing the ladder J or a heroic Remplissage and hoping for the best. So I encourage and counsel most of them to do it regardless of timing in the season. They don't all do it. Sometimes they want to get through the last state meet because their state game because they're not going to play in college, and you do the best you can, but I let them, as much as I can, know the data.
I just want to add a comment, if I may. Chris Jones, who's at UCLA, he's the head team physician for the Lakers. He dislocated his shoulder when he was in high school, and he told me a story that just still rings in my head. Is that when you tell a young kid that let's treat the first dislocation non-operatively, and if it happens again, the kid's at home saying, well, the dislocated the first time, the doc said it was non-operative. The second, the third, and the fourth, he's probably going to say non-operative as well. So next thing you know, it just goes from 1 to 20 before they go back to the doctor. So I think that's important to keep in mind.
Yeah.
So I saw Brett Sanders come in, and he's got a lot of experience. Brett, what is your algorithm for offering or considering a Remplissage? Does it have to have a Hill-Sachs size? Does it have to Tell me about sport. Tell me a little bit about it.
I probably have, an easier population than some of you guys. I get them pretty fresh within a couple of days. Um, and I wouldn't hesitate to put it in, especially on revisions. And a lot of times I'll put it in, as soon as we get in the joint, because it gets tight once you fix them. So I think that makes it technically easier if you do it first and don't tie it. So I think, that's kind of the way I've been doing it usually. But some of it depends on the clinical aspects of the patient, if they're trustworthy, if they're a contact sport. But certainly if it's engaging under arthroscopic visualization. But, I don't have a lot of complex instability. I've always been prone to fixing first-time dislocators. I just think we get better results. When I was training in Europe, in the UK, every patient was like 6 months deep, and it was clearly a different beast. And when we, have a dislocation the week before they see you, they come in with an MRI and you're fixing them a week later. I think that just, that's clearly a better outcome in my hands.
Yeah. I mean, there's some data that suggests that each subsequent dislocation adds a few percentage points to your bone loss. And, by your second dislocation, 90% of people have bone loss. Maybe, Ira, just for the sake of fun, can you play that video? I'm going to just show a video of how I'm currently doing this.
Can I ask Brett why he ties at the end? I mean, I've always done in the beginning and tied so that you pull the head back so you can actually see the anterior labrum that you're going to fix. Why is that, Brett? I don't understand it.
Because it tightens it up and makes it hard to get that inferior capsular shift, which, as far as I can tell, is traditionally the hardest part of the surgery, is to get low in the axilla. So, but then once you do that, and then I'll typically tie that first one to plicate up so I can get deeper plications with each subsequent stitch. So if it's already tied, I think you're kind of getting a false sense of tension. So I put them in, and then so that they're easy to tie at the end, but they don't resist that first. So I don't do knotless, down low. I always do tied, double loaded anchors down low. So I get deep capsular plication as we can, and tie those first. I want that to be the priority, and then that'll be the bolster to prevent the head from anterior translation, and then just have the remplissage sort of neutralize it.
And Joe, I agree. I think for me, it's a lot easier. If I tie, I can sometimes box myself out, and then I don't have as much working room. So I don't mind placing them first. Well, I guess we can run the video. I'll show you what I do. And then this is Patrick. I think you probably gave me the foundations for what I'm doing here. This is hopefully going to play. Spencer Williams is our student. So here you are looking at, as a young athlete, you're looking at a large Hill-Sachs and an anterior labral tear. So my step one is I use the open curette. That's probably my favorite tool. I'll come in percutaneously, and you can see on the right here, I'm coming out just lateral to my lateral cannula, and this is a way of not over-tensioning. Then I'm going to take a small 5mm cannula. I'm going to put it in, but not go through the infra. So I'm through the deltoid, and I'm going to leave that through the deltoid. Now I'll place through the inferior portal, I'll place my first anchor. I tend to use 2 anchors. This is a knotless. In this case, you can tie a knotted anchor just the same. I'll insert the knotless anchor through the cannula, right? So this is through the standard lateral working cannula. I'll pull it out. Again, the knotless. So I'll set the knotless anchor, and I'm going to reach through my and set my second anchor. So I try and get relatively close to the articular margin. I don't know if it's supposed to be exactly on, but now I've got these 2 anchors in place, and I'm going to link them together. So they're linked together, and now you can see that's where they are relative to one another, maybe about 1 centimeter apart. I'll reach in with the penetrator through the lateral, poke through the capsule and some of the infraspinatus tendon, hopefully tendon, not muscle belly, and slide these all out. And I'll put a mosquito on that, and I'll reach back through. I'll poke in again, and I'll grab these sutures here and slide them out. And then now what I'll do is I'll go and I'll fix the anterior labrum. So the anterior labrum is now fixed in whatever method you want to fix. And then I'm going to link suture 1 to suture 2. and I don't get it all the way down. So I link it. I get it engaged, not fully passed, so I don't over tighten it. And then I'm going to sort of link the other two together and then engage it. And then I'll do a sort of shimmy, shimmy, cocoa puff and get them down together again. So I finished the front work. I've got these two limbs out. They're going to self-tighten, pull, 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 pull. I slowly bring them down, slowly bring this tendon and capsule down to the bone. There can be some slack in the system. So I'll pull it a couple of times. And once I pull it a couple of times, I say, am I good enough? I'll cycle the arm and I'll cycle it a few times to get any creep out of the system because it's a lot of tissue. And then I'll tighten again. Now, look, I've not gone in the subacromial space. I've stayed blind the whole time. A little trick that I just showed is I pull out the working portal laterally because I think that can crimp some of the tissue. And I'll do my final tightening, maybe use some Coban in your hand because these don't tighten all the way. And then I'll cut it blind without having tied a knot. And Patrick, to your point, I think that we do this more regularly because it is simple enough. But I guess I'll go to you, Patrick, on technique-wise. Do you have anything to comment on or different than how you do it?
Your technique was great. I mean, I just place through the same cannula. I don't do the second pass, and I just hover the cannula. I take a slightly larger cannula, hover it over the soft tissue posteriorly, and go through that cannula rather than the individual passes you did with a retrograde, but same concept.
Does anyone have any?
Paul, do you worry about a knotless or a suture anchor in a Hill-Sachs defect? I mean, that bone is pretty soft. I don't need to know the exact brand, but what the size of that anchor and what's the pullout strength relative to like a 6.5 or a 5.5?
So, Joe, I worry a lot about that, right? And you're right. If you really get in there within the first week, that sometimes can be soft. And I'll switch over to a screw-in anchor without hesitation. But that anchor is super small. That's like a 1.8 millimeter drill. So if I can be smaller in all suture, I'll prefer that. But I have no hesitation to go to a larger anchor. Anand, what do you say about this technique?
I do something similar more to Pat. I just move. They're still using linked, but I just drill the one and then I bring it across over a bridge of capsule, percutaneously go back in, and then I'll link those through the same cannula after doing the bank cart. But I think yours is even more impressive. Seth was probably doing the surgery, but
Joe, I've never seen one of those.
Job on the
I've never seen them come out. I think that bone, they're going right toward the articular margin on it usually, and I feel like it's pretty hard. What Paul said makes a lot of sense because it just compacts.
What are the complications you've seen intra-op or from a remplissage?
I mean, I've definitely seen
that other that you've seen referred in, Paul. Obviously,
I've seen from Baltimore exclusively. I think, look, you can get some infraspinatus pain and some infraspinatus weakness, and I wonder to myself, and I heard Jeff Abrams say something about it. If I take two smaller bites, so if I didn't link the knotless anchors, if I just do two small knotless bites, so 4 passes, am I a little better off than compressing a larger segment of infraspinatus down? And historically, I would use 2 anchors and I would tie them in with 4 passes and 2 Matricages. So I wonder if there's some over constraint that I'm doing with a larger suture staple. So I'm worried about that.
I mean, obviously, instability, we always worry about the acceleration of arthritis, whether it's recurrent instability without surgery, whether it's with surgery, and what kind of surgery. How do you think this fares in the continuum of care with, having the progression of arthritis compared to a bank cart, arthroscopically, a ladder J, open capsular shift? Any thoughts? Any mechanical data to look at translation of the humeral head relative to the glenoid?
So, Joe, we look with that biomechanical study I referred to earlier. We did see that there was increased stiffness of the joint. So it's biomechanical, but what you just said is my one worry. We don't have evidence of that right now, but I worry that we will be creating some sort of, reverse putty plat sort of type of symptom, right? Where we get some sort of weird pattern of arthritis. But we know they're going to get arthritis if you don't do anything. So
Paul, did you do this? This was great. It's Kevin. So that was really a bipolar lesion. So I thought you did a great job, but there was also bone loss. So for you just hug it up on the front and you were happy enough after this because of the Remplissage?
So, Kevin, that sort of begs the next point where the first line of my editorial is I do Remplissage in 100% of my cases, 60% of the time, right? So I don't think this is the panacea. I don't think if I have a collision athlete with defined 10% bone loss, I'm not so sure that I'm going to do a Remplissage. Certainly in a revision case, I'm a lot slower. And Seth, my partner, will say, gosh, he's probably more courageous with doing something arthroscopic. I raced to the Latarjet very quickly. There's 3 papers that I reviewed and 1/4 one that I didn't review, and I'm remiss about that. But the 2 big popular papers are one from Patrick's series, which is a multi-center series. The second is from the ASCS president Peter McDonald series, and they're both very, very favorable in terms of Remplissage. And Patrick, I'll ask you to get in the weeds on that in a second. Actually, let's do that first, because then I'm going to give you the 2 counterpoints. So get into the weeds about what you really thought and who's indicated and what your multi-center group thought.
Well, I mean, with that multi-center group, I mean, there was 4 of us, right? So Johannes Barth did Latarjet for everyone. Alex did pretty much Latarjet for almost everyone, except some DAS procedures and whatnot, and we left that out. And Pablo Narbona and I were very much on the camp of Remplissage with a 25% glenoid bone loss for the most part for Latarjet, some exceptions, right? Like 20%. So, there was a setup there for what people are picking. If you look at the details, the one thing that jumps out is the external rotation was higher in the Latarjet group, right? But the data really shows that the Remplissage group didn't lose much, at least based on our numbers. But what happened is the Latarjet group gained because we had Johannes saying that everybody improved by 10 degrees. So they started at 70, and then he said they got to 80, and said that was because he made it extra capsular with his repair. But it's hard to know with range of motion because we didn't have one reviewer comparing everybody. What we can be confident about is really the instability and patient satisfaction rates.
So Peter McDonald's findings were very similar to yours. There's 2 other studies, one that Brandon Erickson looked at, and this is a group of 31 patients that he did Remplissage on with the Rothman group, and he compared to 31 standard patients. And he said he found very similar results, right? But they both had a 15% redislocation rate. So that struck me as, gosh, they were very similar in terms of pain and dysfunction, but 15% seemed pretty high. The other study that maybe gets, I think, and I don't want to misquote it, gets sort of underrepresented as Yang, and it's Yang and Arciero in a Latarjet versus Remplissage study. And if you read the abstract, it says there's no difference. But what they really did is they looked at a subset analysis, and in the subset analysis, youths, males, collisions, and revisions all failed substantially better with Latarjet. So I think I'm on board, but I don't know that I'm ready to sort of do this in 10% bone loss. And I'd love for other people to jump in. Victor or Cliff Voigt or Bill, you were quiet last time or on the chat. What do you guys think? I mean, now you're out in practice doing these on your own.
I'll
Rob,
jump in real quick and just say that for me, when I see these, and Pat, real quick, on your paper, I think you filed them for 4.5 years was roughly.
That was probably the average. It was minimum 2 year.
And what was the longest?
It's right around there, but I don't remember that. I'd honestly have to look at that, Sharif.
Okay, no, the only reason I ask is because we know that with the bank cards, traditional bank cards still continue to fall off the cliff. These are not the ones with Remplissage, so I can't equate those as being equal. So my concern here is the loss of external rotation, which has been seen so often with the Remplissage. And when we published our paper just recently on the Latarjet showing that we did not lose external rotation, we were, if anything, at 90-90, we were about 5 degrees short, which was subclinical for to be really clinically valid. Like, did it really make a difference to lose 5 degrees? And it didn't in these patients. However, for me, when you start looking at 10% bone loss and a big Hill-Sachs, it's just, Buddy showed us that if you don't do the Remplissage the first time, there's about a 36% chance of failure when you do a revision and then add a Remplissage. So it's like we're destining these patients to multiple procedures if we don't pick the right one first. So I commend you guys, especially you, Paul, for setting this up. I think we got to figure out what that algorithm is with step one.
Seth Miller, where do you stand on this?
I still lean, Paul, with bone loss cases to go into Latarjet because we've had such great results with Latarjet. Remplissage, it's still in my mind unclear if we can get away with it with a 15% bone loss case. To me, I'd like to do one operation that has the highest success rate. And to me, in those bone loss cases, I move more towards the Latarjet.
Paul, can I ask Seth the question?
Of course.
Seth.
You have to call him sir, though.
I do. Sir, King.
Right, I'll put the video on for this one.
Seth, where does open Bankart near capsular shift in your algorithm of instability? Being a Columbia man yourself.
It's a lost art, I'm afraid, for a lot of people. I think it's a great operation. Paul and I have done a few of them together over the years, but not many. But I think as techniques have evolved, the arthroscopic techniques and greater U.S. experience of Latarjet, I think we're just seeing less of it. But I still use open capsular shift and true multi-directional female. I've done it in a few Ehlers-Danlos patients and with reasonable good success. So I think it's a great operation. I think Near really defined the anatomical defect in those type of patients. But it's just not, I don't see or hear of many people doing that operation anymore. If anybody else here is doing it on a regular basis, I'd be curious to know.
I do it on a pretty regular basis still. I mean, if I have young athletic football, lacrosse, contact sports, it's still a pretty decent part of my population.
Kevin, you got something? Are you on? Do you have any thoughts, Setter?
Yeah, I have to second Annan. I think I maybe I do more of those anterior inferior capsular shifts than most people on this talk. So if I don't have a significant amount of bone loss, they're going to get an anterior inferior capsular shift in my hands.
Nice.
So Annan and Kevin, I have a question. What is your return to sport approximate time after an open shift?
Same 5 to 6 months.
What about
I was going to say,
if I do it through a split, for some patients, I'm not as protecting. If I'm not protecting the subscap as much, I think they get their strength back sooner. So those kids, I can get back a little quicker for contact.
I mean, I think there's a lot of reasons to not say this, but I think there's an appeal to Latarjet where at 3 or 4 months, right, I can pretty comfortably let you go. And I wonder if you lose a little more external rotation with an open shift relative to a Latarjet. I'm not jumping the ship on it. Don't worry. I still support you. It's not anatomic and it's got much higher risk profile. I absolutely agree. But just, look, I'm doing a young hockey player who's trying to play in the pros tomorrow, and his primary operation tomorrow will be a Latarjet.
Too bad his career is going to be so short.
Cliff Boyd, you looks like you have something to say here. Can you please tell Dr. Murthy that kindness is contagious?
All right.
Paul, you say at 3 to 4 months you can let them go with a Latarjet. What does let them go mean?
I mean, I'm going to play.
You're going to let them play. They're going to have no extra support. You're going to let them play professional hockey.
Yeah. And I've done that with Latarjets in football and lacrosse and rugby. This discussion came up like, gosh, don't they have to have protective this, that? Don't they have to be stronger? They have to be lifting in the gym. Honestly, these guys wear a sling for 2 to 3 weeks. They start rehab and lifting right away. They don't get that much atrophy. I don't split. I mean, I don't rather take down the subscap. I split it. I'm doing a deltoid pectoral. So they come back relatively fast. So I do believe that I'm not full of myself. I think that's, Dr. LaFosse agrees that that's the time window, and maybe French athletes don't count. But
do you get a CT scan?
I don't. That, Brett, that's a great question. I don't, because first of all, fibrous union is not significant in terms of outcome, and I don't want to get in their head. So, and I don't want to see it. Well, what do you think? Well, what would you do?
I mean, with soft tissue procedures, it's usually 4 to 5 months. I'm big on functional movement screens, dynamic assessment in real time, and we do the show motion, in vivo, kinematics and everything. So that's what I'm using. I don't do a lot of primary Latarjets. I just don't see a huge amount of bone loss. If I do, it's like a glenoid fracture or something. So I do Latarjet for failed. If one of my own arthroscopic Bancards fails, then it gets a Latarjet basically, because it's going to have some bone loss, and it's by definition failure.
So, but what do you say that, in the opening, we brought up this idea that, the reality is for a collision athlete who's had more than one dislocation, let's call it 2, so who has 10, or let's call it 12.5, so below the subcritical that you guys helped define, like, do you think that person who's going to play a collision sport, is it still a scope Latarjet free, scope Remplissage, or where do you decide to switch up?
I think we're kind of privileged. We cover these schools and they get into us like very quickly. So it's fixing the bony Bancard, with the millet style double row, it's like a fracture fixation. I think if you can get that, then we're on. And then, if you're in that zone and they're coming in at 6 months, I would consider Latarjet. I just worry about the, like a nerve palsy. I've taken out and revised a few broken screws, from car wrecks or early return to play. And a revision Latarjet or a neurologic, problem is way worse, than a failed or a recurrent dislocation. And still in my mind.
I think that's a very fair comment. Roth?
I have a question to ask you guys. If you're gonna do a Latarjet and there's still a big hill sac, do you still do a Remplissage, or do you think the Latarjet is enough?
Anand?
Usually the Latarjet is enough. If I'm doing something with that significant amount of bipolar bone loss, then I'm probably doing something like a distal tibia also with an allograft to the head. But so usually if I'm doing a Latarjet, it's a primary Latarjet.
Do you ever recalculate the track with the added bone?
I can't do that high math.
You need Joe Abood for that.
And then Pat, I wanted to ask you, you said you pretty much do Remplissage on every one of your Bancard repairs. What if they don't have a hill sac? Do you create a hill sac and still put the infraspinatus down, or you only do it if there's an actual hill sac?
Yeah, I don't believe that's really a traumatic, dislocation. I think it's something else. So I don't do it. Only there's got to be hill sacs there.
Great, thanks.
Thomas Evely, have you been doing these?
He's only doing complex arthroplasty now.
He showed me a shoulder fusion that he did today. That was crazy.
He's a man. He's a man.
That was his primary operation for instability, a shoulder fusion. I was confused about it, but I guess, Kevin, that's what you taught him.
Sorry. Go big or go.
I'm just getting back on here. It sounds like some comments about me.
We're saying that what we want to know about your indications for instability. We saw that you fused the shoulder for a first-time dislocator today.
Yeah, that's my go-to operation after today. It went so well. So that's what I'm going to do from now on. No, so I trained with you, right? So, primary Bancard plus or minus Remplissage. That being said, I've got a Latarjet on Friday. So,
Thomas, you going to do any open shifts?
Maybe, to be determined. I have not done any. I think that's one that is a very technical operation. And my biggest fear is messing with the subscap.
Yeah.
Oh, you need to come back north then, Thomas. It's Kevin. We'll get you there.
One more year, Thomas.
I agree, Seth.
Don't believe him. He's been saying 1 more year to me now for 20 years, and I'm still in my fellowship.
So along those lines, what do you think about messing with the subscap in terms of, I know sometimes we split the subscap, but actually taking it down with these patients and repairing it, what is anyone's experience with that?
If that's your house you're in right there, you're making a lot of money as a young attending. Married well.
I will tell you that Rich Hawkins taught us to do it the way the Matson does it. We don't peel, we don't do anything. We cut it, do it, go for it. And he has not had that negative experience that others may have had, but I'd love to listen to everyone else.
I mean, Seth, you can comment on how you do it.
Yeah, I think, in a young person, if you take the subscap down properly and repair it properly, we haven't seen an issue. And spending a year with Near, and we just didn't see subscap issues, barring some post-traumatic events. But so I think you can take it down and repair it with good success.
I've never taken it down. I always split. And Ian Hurley had a systematic review that showed that the ones that were not taken down, that you did a split, did better than if the tendon was taken down. So I just do the split.
So just sort of pulling a little bit of a pivot, Shirag Sheth, who is now applying for his sports fellowship. So anyone who needs a super sports fellow, jump in on him. He's like, wait a minute. It's like, we're all distal tibia allograft. We talk about this all the time. It's not even coming into the discussion. So let me throw this to Patrick and Don Buford. When do you use a DTA as compared to a Remplissage, Latarjet, or a DTA? Give me some algorithm. First, Patrick, then Don.
So I've moved to arthroscopic bone blocks over the last 6 months. My absolute indication is over 25%, but I consider it beginning at 15% in cases like very high demand, young man, or failed previous instability procedure.
How are you repairing the bone, fixating the block?
Right now I'm doing the suture cerclage technique. That's a tension suture cerclage. I know Ivan's data suggests that at least with a frozen graft, you should only use screws, but he was using a button technique. I think what I'm doing is a little bit different because it's drilled from the back and it's linked fixation that you can tension quite strongly, but I don't have data to back up that statement yet like Ivan does.
And are you using a fresh graft?
I've done fresh grafts and I'm just, I'm going to transition to doing frozen because I feel like the fixation is good. I realize that's a risk, but based on what Ivan has showed, but I'm, there's obviously the cost, right?
Yeah.
I may be kicking myself because I've watched Ivan do it. He's a great surgeon, but I'm hoping this fixation technique is going to be better than what he was able to accomplish with buttons. And I'll be able to have a cheaper graft source than a fresh graft that's hard to obtain and very costly. It's $7,000, I believe, at our center, versus the frozen graft is a couple $100.
Don, and then anyone else on distal tibia?
Yeah, no, I've had good success doing Latarjets up to around the 20% bone loss on the glenoid side, so not that much different from Pat. Beyond that, then I'm looking at distal tibia. I haven't done a bunch of them, but I'm typically doing it open still, just because of the volume that I have.
Anyone else, any commentary on their distal tibia experience?
So for me with Latarjet, I'll go up to about 25 is probably your max because you're only going to get about 13 to 15 millimeters with a Latarjet, which is pretty much about 25 to 30% of your glenoid. So at that point, then I'll go to a distal tibial allograft when through a split.
Yeah, look, I mean, it's very appealing because it's an anatomic operation in the sense that you can split in that if that person subsequently needs shoulder arthroplasty, you have not manipulated the anatomy and it makes for a better replacement. So it's appealing, but once again, there's some concern about some resorption. And then can you do it arthroscopically? And what is the fixation? And are screws better than buttons or cerclage? And all to be determined. But I figure once I'm at that point, really, my margin for another operation gets more and more. I get more and more anxious to try something exciting in a second or third operation.
I have a question. I can't get the DTAs where I am. They're just too expensive, and the insurance companies delay them. I've had a couple of glenoid fractures where I've done autograft distal clavicle. Anyone, have experience with that, or do you know the literature, basis for that and pure play instability or fracture?
Anna, you want to talk about your experience in Tokish, or Joe? I think you've done it too.
Go ahead, Joe.
Generally, I found it's kind of soft and not very robust. One of the things that we've done a cadaveric analysis on, we've used it clinically, is the distal radius allograft, the dorsal aspect of the radius. If you take it, the actual convexity of it as you go towards Lister tubercle is pretty restraining compared to the distal tibia. And the bone density, surprisingly, is very comparable to the distal tibia. So it's a good option. Price point, I'm not sure. It's probably comparable as far as price point, but it's an interesting technique that I've been working on.
There's no cartilage on it though, right, Joe?
No, there is. It's distal radius. It's the distal radius.
Anna's not aware of the radius as a joint or the wrist as a joint.
I don't go past the elbow. I don't go past the elbow. I got it. I agree with Joe on the softness of the distal clavicle. That's why I would be concerned about using it. But I like distal tibia, especially for large vertical bone loss. You can really get great coverage, and whether you do it open, split, or scope.
One anecdote.
Don't you do a lot of arthroscopic Latarjet? Maybe you can comment on frozen grafts. Do you have any frozen graft experience? I don't think you heard me.
Yeah, Patrick, who are you asking that question?
I was asking Sharif because I thought, don't you do a lot of arthroscopic Latarjet?
I have, yeah. And so with the DTA, I will use those. I do them frozen, and I use screws with that through a split, and then fix the capsule up and over it. So essentially, it is extra articular, even though it does have cartilage. And if they blow through it, then they have the DTA to drive on. So that's what Ivan has done. There are multiple articles that show you don't have to fix the capsule. Marauder's paper showed that you didn't need a sling, and he didn't fix any of the capsule. However, I think the frozen is more than enough. And going back to the resorption, I think it's really remodeling. I think Ivan's work is showing that as well, that it's when he put them in really big initially, they resorbed, and then he had these big screws sticking out. But as he's been able to cater the size based on some algorithms he's working on, he hasn't seen that much resorption anymore. So I think it really is Wolff's Law and how it remodels.
You got to remember, though, with the frozen grafts, your cartilage is going to die. So that whole the cartilage will die, the matrix will degrade. So you will end up with just bone left. So if the head is going to pass, like you said, blow past the capsule, it's going to be riding on bone eventually. So just keep that in mind.
No, you're absolutely right. And I think that's the key of trying to fix that capsule, and some of those second looks to take out a screw or take out those buttons that, Ivan did. He noticed that capsule was still intact. And so when he was taking the screws out, he was outside the joint. But you're absolutely right. I mean, and then to go fresh on every one of these is remarkably expensive.
All right. So I want everyone to get ready to go to the chat. Let's throw out a case here. And I want you to sort of poke in your operation that we're going to do so that we can have some sort of evidence-based consensus medicine. So you have a 20-year-old male. He is a college lacrosse player. 3 years ago, he had a small bony Bankart. You repaired the bony Bankart, and you repaired the bony Bankart arthroscopically. He returned back to play. He said, look, I was fine. Maybe I felt it, maybe I didn't. But he's diving through the crease, takes a shot, lands, his shoulder comes out, pops out, stays out, and he comes back in to see you. Now you get an MRI scan. He's got a recurrent tear. You get a CAT scan. the small bony Bankart never really healed, so he's got about 10% bone loss and an on-track lesion. So revision, male, only had 3 anchors up the front. He's on track. What operation are you going to give him? And just type it into the chat to see whatever, let's see what people say. Okay. Patrick Denard, arthroscopic bone block. Dr. Morell, ladder J. Dom Buford, laser jet. Cliff Boys, laser jet. Rafi Mirzayan, ladder J. Sharif, arthroscopic ladder J. Michael Redler, ladder J. Kevin, ladder J. So everyone is electing bone. What if there is no bone loss? Does that change?
I didn't say bone, Paul. I said open Bankart for 10% or less.
Yeah, we just eliminated you as an option.
Reading is fundamental.
Just make up a fake scenario, Paul. I mean,
did I just make it up? Yeah, I just made it up.
If you had a right, Pat. If someone had bony Bankart and then had another dislocation, it's not going to have 10% bone loss.
Okay, fine. You know what? Geniuses, Wile E. Coyote, you come up. Let's see.
Okay. How about he's
You've got to understand in Greenwich, though, none of those guys have bone loss. I mean, it's a very privileged population.
They're not allowed to have bone loss. All right, Patrick, give me a scenario and we'll vote.
Come into Greenwich with bone loss.
Okay. All right. Same scenario, but he's got a Hill-Sachs interval of, say, 18 millimeters. He's off track. He's got 15% glenoid bone loss. So would anybody do the same, or would anybody add Remplissage or allograft?
No change. He's in the group that I don't like. Ladder J. I mean, is there an operation on and you don't say anything? It seems like there's either a scope or a ladder J. A scope or Patrick, talk about the role of revision arthroscopy in your world for instability.
The role of revision?
Yeah. So who is a candidate for a revision re-repair with or without Remplissage, or just as opposed to where you're going to go back in?
Yeah, I mean, so I look at bone loss, and I also try to look at the previous anchors that were placed. So if somebody has high anchors and they didn't have a Hill-Sachs defect addressed, and they have less than 15% glenoid bone loss, then I'll probably consider a revision Bankart with a Remplissage. It's going to always include a Remplissage. If I think it was well done, or they have more bone loss than that, then it's going to be an arthroscopic bone block.
I think
either way, I'll address it arthroscopically.
I think as you get older too, Paul, the arthroscopic techniques for that kind of scenario probably have a higher success rate.
Yeah.
So the man, woman, bipolar lesion, non-dominant. Those are things you can put in the algorithm too.
Give me a number for older beside your age.
What's that?
Give me a number for what older is besides someone your age.
30s. I'm like, when you get into the 30s and you have recurrent instability and you fail to Bankart, probably ladder J is probably too far. If you have 15%, you can probably do a revision Bankart with a Remplissage and they'll do well.
Where does arthroscopic bone block, like Patrick has suggested, come into play for the rest of y'all?
For me, it's bone loss. In any case you're going to do a ladder J where you have, 15, 20% bone loss, you can do an arthroscopic DTA, Wong style, no capsule and that gives you the advantage of being able to do a Remplissage at the same time.
So is that interchangeable with a ladder J? So now, Anand, you've got a senior at McDonough, and he's going to play at Duke or UVA or wherever it is. And he's got 10% bone loss. So you elect that he needs a bone procedure. Do you decide between an arthroscopic bone block and a ladder J? What is the role of the sling to you or not?
What does he play?
He's a lacrosse player. He's an attacker. No, he's a defender. He's clocking people. He's a defender.
And it's his dominant arm, stick arm, stick side.
Yeah.
So for him, I would probably lean towards a ladder J. Because he's got to play, he's got to get it healed, he's got to play in the fall when he's coming up, fall ball, and he wants to get back. So that's a person I do a ladder J on. If he was, and that's why you got to put in all those parameters into your decision making.
Anyone else want to help me decide when you need an arthroscopic bone block versus you need the sling effect, and which is more important and less important?
I'll give you a great example of a place to do an arthroscopic bone block so you can have remplissage as a seizure patient, in my view, because with seizure patients, we know they have a high risk of recurrence of Latarjet because, I think because you get that flexion. And so you can do a bone block and you can do a remplissage in the same setting.
And I love that, Patrick. I think that's a great point. I would also emphasize in that case, I'd really use your cerclage technique or try to avoid screws so that when they bend or break your screws in the future, you're not as in trouble. I think less is more. I see people at conferences all the time present on, doing bipolar grafts and all this work on the seizure patients for them only to subsequently break those, and they get stiff. And I don't know if anyone else has thoughts, but that's my feeling on less is more for that patient who's going to revisit you.
That's the patient I would really push to use the buttons, non-screw fixation, because I've seen so many fail, and then they, when you have metals and they get to you late, and these screws are in the joint, and it's really, then you can go to your shoulder fusion.
All right. We got 4 minutes left. Ira, you want to take control of the wheel again? I seem to have stolen it.
I am now muted.
Ira Burgundy.
Yeah, you didn't steal it. You borrowed it for a short period of time, and for now, and incredibly well. This has been an amazing group, an amazing talk. As a joint surgeon, I learned a ton. Sometimes the questions I ask is how complex are these operations for some more everyday surgeons, but that's for another day and another time. I want to share first of all, I want to thank everyone, all of you who participate in this, especially Paul, who really took the crown on moderating, and just superb. And thank you so much for that. I'm going to share my screen, which with this course, which some of you may have heard of, Shoulder 360, April 13th to 15th. Okay. We have our course co-directors, and I think most of our faculty is probably on this call, which is quite good. So I would like to mention very much thank you to Paul, Rafi, and Joe for running this course. And tonight's Journal Club was because of the great editorial by Paul on Joey, Journal of Orthopaedic Experience Innovation. I just want to share one more thing for those of you who don't know a lot about the journal. This is the journal itself. We just came out with some new articles. This is our publishing analytics for 30 days for people who don't know. We have about 13,000 page views, 10,000 article page views, 7,000 unique visitors every 30 days. And since inception, which was March 14th, 2020, the first day of COVID, we almost have 200,000 page views, 138,000 article views, and nearly 100,000 unique visitors. And I do want to thank Michael Redler for visiting 56,000 times. So thank you, Michael.
Anything I can do to make your numbers look better, Ira, it's one of my main goals in life.
Yeah, I can imagine. So I'm going to close it up with asking Paul for some closing comments. Paul, remarkable job, and all of you, thank you. I don't want to mention anyone's extra name. because I don't want to leave all of you great surgeons out. I just want to thank everyone who came on board. Paul, some final comments?
Yeah, well, first of all, Ira, thank you, and thank you to the journal for creating a platform for us to share and learn from one another. The second thing is April 13th, like Rafi told me, is going to be Shoulder 360. So I hope I see you there. The final comment is I really don't believe this is a solved problem. I think that Remplissage is going to be a great thing to do, and it's technically easy to do. Will we later reflect back that we overconstrain shoulders? Should I not be linking? Should I be doing individual mattresses? I don't know yet. I do know, the only thing that I really do know is that the recurrent dislocation rate in these collision athletes is higher than we're willing to accept. So I would like to work towards strategies that are more anatomic in restoring their anatomy. And I think that everyone on this call, whether it's Anand, Joe, Sharif, Thomas Evely, Patrick, have all contributed to what I understand and how I approach this. So I appreciate it. And Don just the same. I appreciate all your time, and Brett too. So thank you.